Hi, I'm Hal David Martin here at the Hip Preservation Center, Baylor University Medical Center in Dallas, Texas. And so today we're going to go over a couple of things with you, and hopefully it helps you with your rehabilitation. Some of the key components, both for anterior, we're going to make another section for lateral-based hip pain, and then finally for posterior-based hip pain. So we're going to go over the specifics and some of the keys for each of these areas to help you with your rehabilitation. This is Kara, and she's going to help us today to demonstrate these different areas that are important in rehabilitation. When the patient comes in, we want to make sure that the crutches are proper. Bobby's going to go over this, but we like the crutches just one hand breadth below here, and we like the hand at 45 degrees like this on the crutch. And on both crutches, and that's the way that we like both of them. The patient can be weight bearing usually, but we don't want to weight bear and twist. So that loaded motion with twisting is where we can get into trouble. But straight down with the crutches is allowed, and we can start practicing really double arm support with single leg stands pretty early in the process as long as they're not having pain. So that's one of the key first elements on the standing aspects of the rehabilitation. So for anterior hip surgery, let's have you lay back on your back. Couple of different things here. So the patient will lay down, and one of the key elements after we have control of swelling, we want to make circumductions. And so circumductions, and for most females, if they don't have any instability, is that we can do this in neutral, where the knee and the ankle are lined up, and we can make a circle, 20 circles twice a day like this, just to get good passive motion to prevent the scar tissue from occurring on the front hip. If you have a patient that has retroversion, then we want to do that in external rotation so that the knee is outside the ankle, like this. So in this, the knee is here, but we don't want to go too far up and out like in an Irish dancing because there can be some instability, especially in females. So mostly with females, we want the knee and the ankle lined up. Males, sometimes you have to go, if they're retroverted, we have to do the circles and external rotation. And that's a key component. They'll never be able to get all the way maximum internal rotation and maximum hip flexion if they're retroverted. So we do that. We check and make sure they can do a negative Thomas. Hold this up for me. And this is how we stretch the anterior left hip. And this is the one that we're operative or playing like we've operated on this side to make sure that this goes all the way flat, because the psoas has a tendency to try to get really tight. So, and after that, the next thing on the first couple of weeks, and even through the first 6 weeks, is to continue to ride the bicycle for 30 minutes, 5 days a week with the seat height maximally and getting all the way around on the pedal. So those are some of the key elements for the standard anterior hip that we need to make sure that the patient is comfortable, no swelling, can begin double leg balance, and then if we can do that, we can progress on with the rehab program for the anterior hip.